I really appreciate it. Thank you so much to the MHTTC for having me back. I'm really excited to talk with you all today. Before we begin, just, I want to just make sure that we acknowledge that my disclosures, which are that I did have funding available for the project that we talked about mostly last time, but I just wanted to make sure that I mention that again. The grant was made possible by Eugene Washington COVID-19 Enhancement Award from the Patient-Centered Outcomes Research Institute to the Ohio State University, and the principal investigator at that time was Dr. Glenn Martinez on it, so I want to acknowledge that. And I have no other conflicts to disclose for this presentation today. I do want to acknowledge some of my partners again from the last webinar where we went over the findings from that project. This is just my team, and I'm really grateful to them, and obviously very grateful to the Ohio Latino Affairs Commission for their ongoing support of these efforts. And then just to kind of give you an overview of the objectives for today, right there, sort of at the top, we have what part one covered was really looking at the impact of COVID-19 on the Hispanic and Latinx community in Ohio and going through the data that we collected as part of that project. But today we're going to talk a little bit more about how we move forward. But in order to do that, we really have to talk about where this all began. So the reason that Hispanic and Latinx communities have been disproportionately impacted by the COVID-19 virus is because there have been some structural inequities, longstanding, that have contributed to that disproportionate outcome. So we're going to spend some time at the beginning of this presentation really sort of talking about the history and sort of why those structural inequities exist to begin with, in order to inform how we're going to move forward for COVID-19 recovery in this population. We will outline the recommendations for recovery in a culturally relevant context, and then outline recommendations specifically to promote behavioral health and mental health equity. Obviously, this is the National Hispanic and Latino Mental Health Technology Transfer Network, and so we want to make sure that we emphasize that. And as I mentioned in our last webinar, the mental health impact was really one of the primary reports out from the participants in our project regarding things that really had impacted them. So we want to put some emphasis on that as well. So just a brief review from part one. I won't take very long, but we know that there was a disproportionate impact of COVID-19 on the Hispanic and Latinx community nationally. We went through some of that data. When we looked a little bit more locally to Ohio, we took a snapshot of that impact. And again, our project did not necessarily represent all of the Hispanic and Latinx community members here in Ohio. It was just a snapshot, but it gave us at least a sample of what that impact has been like, both in a quantitative standpoint, so having some hard numbers to it, but then also some qualitative data. So hearing from our community members themselves, using their voices to really articulate what the impact has been. Mental and behavioral health concerns were frequently reported and central to people's experiences. So again, that was a point that they emphasized over and over again as the COVID-19 pandemic, having that profound effect in that domain. But despite those significant impacts, we are a resilient group. As a culture, we're resilient. As a community, we're resilient. And some of the findings from the project sort of highlighted that. Things to sort of focus on in terms of strength-based approaches, things to really highlight in terms of our own individual and sort of collective resilience, and how as a culture, our resilience sort of helps promote, ongoing ability to cope with all of the ongoing struggles with the pandemic. So again, we're going to sort of go backwards a little bit before we can go forward. So we're going to talk a lot about structural inequities that have been longstanding, that have basically laid the foundation for where we're at right now. So this is probably an image that you've seen before. Basically, it just sort of outlines that there's a lot of things that goes into an individual's health outcomes. And what this picture sort of depicts is that, frankly, a lot of what goes into, or a lot of the variability that goes into one's health outcome is actually controlled by some factors that you might not necessarily expect, right? So if we look just at, health behaviors, that's 30% of what contributes to a person's health outcome. Those are the things that we typically target in medicine, right? We target behavior change. Weight management, we target healthy dieting, making sure you get exercise, quitting smoking. All of those are health behaviors, and that's sort of what we target, or traditionally have targeted in medicine. But if you look at all of the other things that account for one's health, socioeconomic factors, physical environment, so that's what we call like built environment, all of that can be traced back to your zip code. And then 20% is about healthcare, so sort of your healthcare moments or your healthcare interactions. And we know there are some barriers to that too. So if you look at what causes the variability in health outcomes, you're looking at a large percentage of it being determined by things that are structural in nature, meaning things that maybe aren't in an individual's control. And sort of this idea that it sort of ties back to your zip code gets into that social determinants of health idea, right? It's basically this idea that it's not necessarily your genetic code that maybe determines a lot of your health, but rather it's looking back at your zip code. So why is that? Basically because of the impact of structure. So structural conditions influence life chances. So in some ways, chances both socially and environmentally determined. And so what do I mean by that? But basically, if structural conditions can impose constraints on opportunities. And that's the thing, is that generally speaking, we can only make choices that are associated with opportunities that we are afforded. And we do know that structure puts constraints on opportunities for marginalized communities or communities that have been traditionally and historically at a disadvantage. So when we look at Healthy People goals for 2030, so you guys are probably familiar with Healthy People 2020 goals. We've now moved on to 2030. And really focusing on looking at social, physical, and environments and basically cultivating them so they result in the full potential for health and well-being for all. And in line with this goal, the Healthy People 2030 goal features many objectives related to those social determinants of health. And those objectives highlight the importance of what we call those upstream factors. So usually unrelated to healthcare delivery. So again, outside maybe of the healthcare system that are responsible and needed in order to improve health and reduce those health disparities. So Healthy People 2030 is really asking folks to really look more upstream, look at really the causes of maybe the difference in social determinants of health among our various populations. So what are social determinants of health? As I mentioned, those are some of the things that are tied to your zip code, but they're basically the conditions in which people live, are born, they live, they work, they engage in recreation. It's basically all of these factors that are associated with sort of your environment and your, social sort of context that contributes to one's health. And what we do know is that resources that enhance quality of life in those environments can have a significant influence on those population health outcomes. So again, if we go back to that image of the percentage of what accounts for the variability in one's health outcomes, some of those things are factors that, depending on where you live, depending on the community, depending on the demographic and geographic sort of landscape of your area, you may not necessarily have all of the resources that you might find in other locations. And so those are important structural things that we need to consider. So these are actually the social determinants of health: education access and quality, healthcare access and quality, neighborhood and built environment, social and community context, and economic stability. And what I'm going to do now is I'm going to highlight each social determinant of health, but then I'm going to talk about the structural factors that play a role in those social determinants of health. So again, sort of the things that have caused inequities to begin with, which were then exacerbated with the COVID-19 pandemic. Because again, I don't think we can really move in the future or move towards a more equitable future if we don't try and understand what were sort of the root causes of some of that inequality. So we're going to talk about economic stability. So really, when we think about structural analysis, so looking again at the structure that's really impacted economic stability, we know that redlining is probably one of the most profound structural factors that plays a role in ongoing economic stability for families. So redlining was the practice of mapping areas, primarily where Black populations resided, in red ink as a warning to mortgage lenders. So basically, lenders used redlining as a way to sort of demonstrate or sort of indicate credit risk. And then they would sort of deny investment or deny loans in those areas. So they basically marked these areas off, predominantly Black, but also brown areas. They basically mark them off and sort of cut them off from economic investment. The reason why that's really important is because the lasting impact of that still felt today. So the greatest way or the biggest way to create generational wealth or to create generational resources and wealth opportunities is to own property. But because of redlining, there was a legacy or a longstanding policy in place that precluded folks from potentially owning a home or being given a loan to own their home. And again, if you think about that being the biggest generator of generational wealth, we have certain populations that were significantly behind other populations, such as our white population, in terms of home ownership. So historically, redlining was used to deny minority customers loans and housing opportunities. So actually, if we look at redlining, more local to Ohio. So this is actually Cleveland. This is where I'm physically located right now. So on your left hand of your map or of your slide right now is a map of redline neighborhoods. So, and it's effectively, again, red indicates sort of those areas that were sort of marked off, predominantly where Black and brown individuals lived, that basically said, hey, this area is a high, quote unquote, high risk neighborhood. And so economic investment was sort of precluded in those areas. So you'll see red lines on the red light areas on the left-hand side of your slide. That generally looks like if you overlay that with something called social vulnerability, which is on your right-hand part of the slide. And social vulnerability basically, we'll talk a little bit more about it in a second, but it basically means the ability of a community to respond or recover from a crisis or a disaster. Basically, it has to do with some of the economic and social resources that are available in that area that help a community be a little bit more resilient to the impact of crises. And so areas that are in pink and red are sort of areas with higher social vulnerability, meaning they're more vulnerable to disasters because they don't necessarily have all of those resources that we just talked about. If you look at these two maps and you were to overlay them on top of one another, you would see that a lot of the areas that are socially vulnerable now, currently, these maps are from like 2018. So 2018 map very closely onto areas that were redlined back in the 1930s when that policy was in place. So again, talk about the lasting impact of redlining, what that policy did in terms of creating inequality. This is Columbus, so this is maybe where some of you are watching this presentation from. And so Columbus, you sort of see the same pattern bear out. Again, on your left-hand slide is a map of redlining, and then on your right-hand slide is a map of social vulnerability. Again, if you look at your redlined areas in Columbus back in the 1930s, those same areas, a lot of them, again, are, if you overlay the map, they would match up with areas that are determined to have a higher social vulnerability index score, meaning, again, those communities are more vulnerable to disasters or crises because of a lack of resources and a lack of a variety of other factors, which we'll get into. So you might be saying, well, that was in the 1930s, you know, redlining was a long time ago. So obviously that doesn't matter anymore, but it does, because redlining, although it's legal and it was banned, it's still hurting minorities today. These are headlines just within the last year or two. Redlining is illegal, but it's still hurting Latino families. And again, the population most affected by redlining was your Black population, but your Black and brown communities as well, including Hispanic and Latinx communities. Those communities are also have been adversely impacted by the legacy of redlining. And as you see from these headlines, it's still something that plays out today. So again, I mentioned social vulnerability on those maps. It just basically refers to potential harm to people. So again, it looks at the resilience of communities, so their ability to basically cope or deal with a disaster or a crisis, you know, in terms of how well that they can cope with those events. And so social vulnerability is basically an index score. And the way it's developed is through looking at all of these different factors. And then you get a score somewhere from 0 to 1, with higher scores indicating, again, more vulnerability, lower scores indicating less vulnerability. And so it's basically a cluster of all of these factors that go into that score. This just sort of lays that out. And then now if you look at Ohio, so again, now we're getting more local again. If you look at areas that have a higher social vulnerability in Ohio, that's going to be indicated by your reds on this map. You can see where sort of, again, it overlaps with some of those areas seen through those redlining maps. Cleveland in your sort of northeast corridor, there's a high propensity of red. It also falls in that same like sort of redlined map. And then Columbus there in Franklin County, sort of in the center of Ohio, slightly south and maybe slightly west, but sort of in the center of Ohio. Also, you see that red and sort of that T, if you will. That is also, again, a very close overlay of the history of redlining. So again, we're talking about vulnerability even now that is linked back to that structure, that policy that occurred in the 1930s, which still has a lasting effect on community prosperity and community opportunity even now. And again, to sort of link this back to Hispanic and Latinx communities, in those same red areas, you see a greater preponderance or greater percentage of Hispanic and Latinx Ohioans in those areas. So in terms of other social determinants of health, education, access, and quality. So we know that from the COVID-19 pandemic, educational gaps were likely also exacerbated. And there's reasons, again, because those gaps already existed. Part of the reason that those gaps existed is because, again, structure that has been longstanding. So there has been longstanding educational inequality. We know that certain poor performing schools tend to have certain factors that are associated with those schools. They tend to be of a larger school size, have larger class sizes, have a lower quality curriculum, and have less qualified teachers. So just maybe teachers who are newer to the field, maybe teachers who don't have some of the more advanced certifications. So those are schools that predominantly also serve Black and Brown communities that tend to be located in urban cores or urban communities, which, if you get back to our social vulnerability, are also located in areas that tend to be higher in social vulnerability. So these factors were in place before the COVID-19 pandemic. These educational gaps were in existence before the COVID-19 pandemic. But those gaps were exacerbated by the COVID-19 pandemic because of the, being removed out of their school, so having to do virtual schooling, and some of those schools that tend to be the poor performing schools perhaps didn't have the sufficient resources that maybe other schools in more suburban areas would have. So again, you can kind of see how this inequality would have been worsened or would have been more stark given the context and given sort of the circumstances of the pandemic. When we talk about education access and educational equality, we also have to talk about the school to prison pipeline, because it also disproportionately impacts Black and Brown communities, including Hispanic and Latinx children. So this idea of the school to prison pipeline is basically a conglomerate of policies, procedures, practices that will sometimes result in suspensions or expulsions, which then can potentially lead to entry into the criminal justice system through sort of a linkage in terms of over time. And so when we talk about the school to prison pipeline, we know that Black and Brown youth do experience higher rates of suspension and expulsion than their white counterparts. And that can be for things the things that sort of contribute to that school to prison pipeline are things like harsh school discipline, zero tolerance policies, or increased police presence. So, and what we're talking about when we talk about harsh school discipline or zero tolerance policies, we're talking about pretty significant consequences for minor infractions. So this would be things like dress code violations, talking back, loitering in the halls, and maybe, one infraction, another infraction then leads to some of these harsher school discipline strategies being implemented. And the concern with that is that if there are inequalities in sort of how discipline is handed out, then it impacts Black and Brown students in an adverse way. So we do know that there are racial disparities in discipline and a disproportionate impact on marginalized youth in terms of this process. And this is really important because suspension in and of itself is a disruption in learning, but for Black and Brown students, it can be particularly significant because suspension, even above poverty, is a biggest predictor of school dropout. And so if you think about, again, sort of the long process here, the long game here, increased school dropout leads to likely, lower income, which then leads to, again, sort of economic inequality. So again, this process starts very young. And so it's really important to understand what these factors are, what has been in place in order to really think about how do we address these educational gaps for our Hispanic and Latinx youth in Ohio moving forward, especially in the context of the COVID-19 pandemic. So here we're also looking now at structural analysis in health. So we're looking at sort of the social determinant of being healthcare quality and access. And so you'll see that access, quality, and equity is really sort of the end result, but it's the end result of a lot of like upstream factors, and the uppermost of those factors being social structures and health policy. So that really can impact an engagement in the healthcare system, the care that you receive in the healthcare system, and then obviously your healthcare outcomes. And what are some of those structures or things that might contribute to it? So we obviously have, discrimination, racism, xenophobia that can play a role in terms of the healthcare system, sociopolitical landscape and discourse in terms of engagement. So, just as an example, if there's anti-immigrant sentiment, it may cause individuals who maybe come from mixed status households or immigrants to be more resistant or more reluctant to enter the healthcare system. There are structural barriers to services that are a result of just, again, longstanding policies, processes, and procedures. Language accessibility is not necessarily a complete guarantee in healthcare systems in terms of it meeting the needs of individuals who encounter. So again, all of those processes and policies in place that govern language accessibility may make it more challenging for some folks who have limited English proficiency, so our Spanish-speaking population, to access the healthcare system. And then obviously we have concerns regarding cultural and linguistic competence of services. One of the things that we know is that despite treatment need, Hispanics and Latinx individuals do not access the mental health care system in particular, despite significant treatment need. They do not engage in treatment. They don't stay in treatment at the rate that they really should, given the identified treatment need. And we've heard that, anecdotally and just in terms of research. There's research to suggest that one of the factors that really contributes to that lack of engagement in behavioral health services is the perception of a lack of cultural and linguistic competence, basically agencies or organizations not being able to meet the needs of our community. So this is just an example of, again, where structure interfaces with the healthcare system and potentially can cause some disparities. So the legacy basically of anti-immigrant sentiment and then the public charge rules. So that resulted in the avoidance of public benefits. And that actually was really bad timing because it also sort of coincided a little bit with the pandemic. And so you have individuals who might have even been eligible. We heard, stories for sure from some of our participants in the focus groups that they, even though they might have been eligible or their children were eligible, they did not necessarily apply for things like Medicaid or CHIP, or they withdrew from those programs for fear out of what that might mean for their status here in the United States. And so if you aren't accessing those public health programs because of this policy that is in place, that's going to create more housing instability and economic insecurity for our Hispanic and Latinx community. So again, you see the impact of structure, the impact of something that was not necessarily tied to the pandemic, but something that existed prior to the pandemic, that then trickles down to have an effect at sort of every level, that then potentially results in those negative health impacts for our Hispanic and Latinx community, and then exacerbates the impact of COVID-19. So this is just sort of a cluster that's meant to sort of reflect that a little bit in terms of sort of the complication or sort of the complexity, if you will, of the healthcare system and sort of what maybe goes into someone being able to access the healthcare system. Again, racism or discrimination, existing longstanding history of sort of mistrust of healthcare systems, social needs that may not be, that may preclude you from being able to prioritize some of those healthcare concerns. Cost obviously can be a barrier for a lot of individuals, and then legislation, like we just mentioned. So things, the public charge rule, things like that, that may have influenced someone's inability to access healthcare. So let's talk about neighborhood and built environment now. So basically, we're talking about residential segregation, and we know it's a fundamental cause of racial disparities in health. So the effects of racial segregation are often pretty stark with Black and Hispanic and Latinx communities in highly segregated and also often like isolated neighborhoods, where those neighborhoods tend to be associated with lower housing quality, substandard housing conditions, overcrowding in homes, exposure to environmental hazards, isolation from essential resources, so not just being able to access resources as easily as you might in like a suburban area, and higher concentrations of poverty. And so as a consequence, the residents in these neighborhoods tend to experience greater stress and have a greater risk of illness and death. What is particularly important is, or all of this is really important, but one thing I do want to mention or highlight is that exposure to environmental hazards. The reason why that's important is because generally speaking, as a country, we have a history, sort of a, again, sort of the unfortunate past or sort of those unfortunate pieces of our legacy of clustering environmental hazards in certain neighborhoods. Those certain neighborhoods tend to be neighborhoods that have a higher population of Black and brown individuals. Again, it goes back to redlining and all of that, lack of resources, lack of economic investment in these neighborhoods. But the reason I want to highlight that is because long-term exposure to some of those environmental hazards can result in things like asthma, lack of fresh food markets, things like that can, potentially, lack of built environment where you can get exercise safely, be able to walk, can result in things like diabetes, obesity, right? So, and all of these things put people at increased risk for complications and more severe outcomes from COVID-19, right? So again, all of this is related. This is a long-standing issue, clustering of environmental hazards in certain neighborhoods, residential segregation or racial segregation in residency is also a long-standing issue. Put all of that together, and then you had a population that was more at risk for negative outcomes from COVID due to some of their health conditions that were a product, or at least partly a product, of the environment that they lived in and grew up in. So again, all of this is all related. And I like sort of the tagline at the very top, not everyone has the same opportunity to be healthy. That's the whole point of sort of this first part of the presentation today, is there were structural factors that really preclude some individuals from living their healthiest life possible, from having, social determinants of health that are associated with positive outcomes. And so this just sort of outlines a lot of that. And the last social determinant of health and structure relationship that I want to talk about is social and community context. And then as soon as this part is over, we're going to get into, a little bit more of the recommendations because of what we're talking about. So really what we're talking about, or what I'm going to focus on, is social capital. And so social capital is basically, the ability for individuals to develop sort of trust, connections, networks that then lead to additional opportunities. And so basically, if you think about this, I like sort of the bottom part of the slide is like an example. If friends or organizational ties help someone access resources they need to achieve their goals, they represent social capital. An organization or individual may only know a few people or institutions, but these connections help them find stable employment or improve the quality of life in their community. That individual or organization has positive social capital. So when we think about community, social capital is really important, and for individuals within that community to access resources, to find stability, find those social connections that then again offer more opportunity. The key here is trust, right? And so when we think about having to develop trust in these connections and these networks to then access those resources, if trust is central to that, one key way to erode trust is to create policies that foster discrimination in some kind of way. So again, we go back to maybe public charge rule and just general anti-immigrant sentiment. So what happens when we have a policy like that is discriminatory or perceived to be discriminatory, is it results in mistrust in agencies and institutions, right? If we think, and like I mentioned, it resulted in some folks being not accessing public aid programs, but they develop mistrust in agencies and institutions in general. And so what that results is reduced help seeking and more isolation. So we don't, or individuals, or community members don't necessarily try to engage in those connections, right, or forge those connections to access those opportunities. They're a little bit more isolated now because the lack of trust in organizations is there. I also just want to highlight food insecurity as sort of being a downstream effect of these policies, with, again, not being able to access food stamps or other different programs. It created more or increased food insecurity in our Hispanic and Latinx members who were eligible for those programs. In addition, because of the pandemic, food insecurity in the Hispanic and Latinx community overall increased. And so things like this that reduce social capital do not help basically, they exacerbate these issues. So really what we're talking about is health inequity as a result of social determinants of health, but we're looking even past that. We're looking at the structures or the factors that really produce those inequalities. So real quick, I just want to go through sort of what this looks like in terms of thinking about this in a framework, and then we're going to get into recommendations for structural transformation. So luckily, we have a framework that sort of talks about these structures and looks at these structures as a target of intervention. So structural competency was developed by Jonathan Metzl and Helena Hansen, and it really represented a shift in medical education to really look at more of the upstream factors that contribute to health inequities. And so it really increases the capacity for health professionals to recognize and respond to health and illness as a downstream effects of broad social, political, and economic structures. Again, broad social, political, and economic structures, all of which we just talked about over the last half hour. It's those structures that exist, that are perpetuated, that we have to think about if we're truly going to try and promote equity, especially for in the context of recovery from COVID-19 for our Hispanic and Latinx community. So this is just an overview of the framework. I'm not going to get into the framework in very detailed ways because that's beyond the scope of this presentation, but I'm just going to briefly talk about how this all sort of fits together. So social structures are the things that we just talked about, the legacy of redlining, policy, even though the public charge rule is not necessarily being implemented, the legacy of a potential implementation or an implementation of that. The school to prison pipeline, policies, economic systems, and other institutions that contribute to the vulnerability of communities. So these are the things that cause inequality and cause poverty. And then how do these social structures cause harm? Well, because they don't passively exist. Those institutions, those policies, those practices, they don't passively exist. They are maintained, and they maintain a status quo that basically disenfranchises some individuals while affording advantage to other individuals. And so it's that harm, essentially the violence caused by those structures, that cause harm for individuals. And it's really important to try and mitigate this, but the only way we can really do that is to look at structure as a target of intervention. So structural vulnerability is the risk experienced as a result of structural violence. So think about like social vulnerability, structural vulnerability, something similar. It's sort of the vulnerability experienced by certain communities or certain groups as a result of those factors. And that's what we want to try and mitigate. But to do so means that we have to move beyond sort of individual level interactions, right? You're not necessarily going to fix some of these issues if we are just talking sort of individual to individual, like typical healthcare encounter. We have to look much larger. And then a downstream effect of these social structures is health inequality. So those are the differences in the opportunities groups have to achieve optimal health. Of those opportunities included are your social determinants of health. And then it results in sort of what we see every day, or what we really saw or continue to see with the COVID-19 pandemic, is the health disparities. So that sort of is the end result of all of those things as part of this framework. And so again, if we think about the first part of this presentation, we're talking a lot about structure, structural factors, structural drivers of inequity. If you go down that chain, then at the very end is sort of what you end up with, which is our health disparities that we obviously want to try and eliminate. So when we think about structural inequity and we think about COVID-19 recovery, we have to think about structural transformation. How are we going to change structure, change structural systems, change the downstream effects of those structural systems in order to truly promote recovery for Hispanic and Latinx Ohioans? That's what we're basically going to spend the rest of this presentation talking about. So, and we can't think about recovery without thinking about equity. They go hand in hand, right? We know that COVID-19 is having a disproportionate impact on our communities of color. So in order to think about recovery, we have to look at it through a lens of equity, and that also includes a lens looking at structure as a target for intervention. So when we think about structural transformation for equity, we just first and foremost, we have to think about the public health response. So we really need a more robust public health and state level response to address structural and systemic factors that make marginalized populations uniquely vulnerable. So again, if we go back to that social vulnerability maps, those maps can basically tell you which communities may have a harder time in a crisis or a pandemic such as COVID-19. So really we need to think about restructuring the system to be able to equip and provide resources to those communities who we know are going to be uniquely vulnerable to the impacts of that. And so what would that include? That would include a review of current strategies for how larger state organizations and systems interface with marginalized communities. So you're sort of thinking like, if we're going to get better at this, we have to know where we're at. So a current review, basically, how do we interface with marginalized communities? How are our resources allocated to those communities? And then how do we utilize those communities to help inform some of our strategies and activities? That's really what's needed, is to sort of start from the beginning, almost start from scratch, and almost recreate the system. There's a lot of individuals who say, like, I just want things to get back to normal. I just want things to get back to the way they used to be. And while I understand that, the way they used to be was actually fairly inequitable. And so really, this is an actual opportunity to really reimagine a system, really reimagine a series of systems and structures to actually promote equity, because we don't necessarily want it to go back to the way it was, when the way it was before was frankly, very inequitable for certain groups. And so really trying to not go back to the status quo, not sort of return to that status, but really look at how can we be better and improve, and so that we don't have disproportionate impacts for the next crisis that occurs. And that really revolves around, again, starting at our home base, figuring out what we're doing currently and how we can improve those systems. But that should involve the stakeholders, which are members of that community, to help inform that. And so we should have sort of an ongoing involvement plan for continuous and consistent involvement of public and key community stakeholders and members of marginalized communities in collaboration and shared decision making. There is a quote, I might have said it at the last presentation, I can't remember, but there's a quote I really like, and I say it pretty much in every presentation. I find a way to get it in. I don't know who actually came up with the original quote. It's been attributed to a variety of sources, so there's not a specific person I can say the quote belongs to, but there's a saying called "nothing about us without us." And I think that that's sort of just a guiding mantra, nothing about us without us, which means that decisions and plans and activities really should not be occurring for marginalized communities without their involvement, without their intrinsic involvement, right? So you have community members, stakeholders who represent these marginalized communities operating on an ongoing capacity where they give feedback, sort of are consulted regarding efforts at the state level, local, regional, what have you. But they're intrinsically and consistently involved in these processes. Their voices heard, they have a seat at the table in decision making and things like that. So really there should be a plan for some sort of continuous process where there's a community advisory board or some sort of advisory board made up of members or key stakeholders in those marginalized communities to provide that ongoing feedback and to be the voice of that community. And we also need to really have an emphasis on structural analysis and addressing those structural inequities as a root cause of disparities. So really looking at, whether we're at a state level, local, regional, whatever we're doing, but just looking, even at an individual institution level, when we're talking about, redesigning our processes or sort of looking at our processes for how we can serve these communities better, really looking at it with a structural analysis lens, right? Really looking at the structure, the policies, practices, institutions that sort of govern those inequities, sort of govern the disparities that you sort of see as the result. And so really trying to take that and be more intentional about thinking about structure is going to be really important. That will involve cross-sector collaborations and interventions to address structure. No one entity is going to be able to sort of deconstruct the system or sort of reconstruct the system. No one entity is going to be able to be responsible for that. So it's really going to have to rely on cross-sector collaboration. So government, public, private, business, healthcare, education, but really these collaborations across sectors in order to design interventions that are going to have the most impact. And those interventions should be designed to address structure. And we need to invest in ongoing training on combating structural inequalities, including equity, social justice, and anti-racism training. That has to be sort of embedded into, annual training in different institutions or organizations, annual training in terms of thinking about, anyone who's doing work with these communities, they have to receive that ongoing education and really having a focus on providing resources such as that. So when we talk about cross-sector collaborations, we're really talking about trying to produce collective impact. So collective impact is different than what we call more isolated impact. So if you think about isolated impact, an example of that would be a single entity doing good work in a certain space, right? So you think about nonprofits, maybe that might be a good example. They apply for funding, they receive a funding, and then they institute a program. That's sort of the traditional model. The problem with that is that impact, although there's a ton of value in that. So I'm not in any way knocking isolated impact. There's tremendous value in isolated impact. However, we also want to make sure that we're creating more of a collective impact as well. And that means that instead of one entity, one agency, or one institution being responsible for a certain program in a certain domain, rather it's those cross-sector partners and that collaboration across those partners that you're working towards a shared goal. So these are sort of the defining features of collective impact. So it's a very specific approach in terms of how to address really complex social problems. So complex social problems are things like inequality, right? There are social problems that don't have a very clear-cut answer, but are going to require multiple levels, multiple partners in terms of intervention. So these are just the 5 pieces of collective impact. Defining a problem and shared vision for a solution. So that's really important because oftentimes you might get people at the table talking about an issue, but they might have different perceptions of what the actual issue is or what causes the issue, right? So just identifying the problem and making sure that you have a shared definition across all of those entities is going to be really important. Coordinating activities with a mutually reinforcing plan of action. So all the partners are, together in terms of coordinating those activities, but they serve a function and they serve a benefit to all of the parties involved. Tracking data and progress for continuous improvement. So that's, just always being in that sort of mindset of process improvement, looking at data continuously so you can make changes as you need to. Building trust to work towards mutual objectives, and then dedicated to the initiative. So the backbone organization is sort of the entity or the organization that really is firmly or fully sort of committed to the initiative in terms of their manpower and their resources. So they, are organizing the meetings, they're organizing sort of the collective group, they're in charge of the supporting activities, they're building that collective will and sort of mobilizing resources. So one of the, an example of this would be OCHLA, so the Ohio Commission on Hispanic and Latino Affairs. They sort of serve as a backbone organization for a lot of the mental health work that we're doing as part of their sort of strategic plan on the mental health and behavioral health side. They provide a lot of support. They issue the mental health newsletters. They bring trainings and webinars such as this one. And so they sort of are a committed entity to sort of making sure that we are working towards that shared goal. So that's just an example of a backbone organization. But without a backbone organization, collective impact efforts will fail because we really need one, at least, core body that's dedicated to the initiative specifically. And so we talk about cross-sector collaborations. I don't want to not talk about those without community partnerships, because community partnerships are going to be key in any sort of collaborative coalition work or, again, a collective impact effort. So in terms of community partnerships, it's really going to be important to continue community engagement and outreach to our Hispanic and Latinx community here in Ohio. And that really means partnering with CBOs or MCBOs. So partnering with community-based organizations or minority-based community organizations. So community-based organizations that are owned or run by racial and ethnic minority individuals. And because they're already doing a lot of the work. So those CBOs and MCBOs, for the most part, they are boots on the ground doing all of the work. They're the entities that the communities trust. They're the entities that really provide for the resources and needs of the communities that they work with. And they're doing such great work, and they're often doing it on a shoestring budget. And how they do all of the good things that they do, is always baffling to me, because they do it with limited funds. And so really trying to amplify and prop up some of our community-based organizations and minority community-based organizations. So, we have SUCASA down in, Southwest Cincinnati, in the Cincinnati area down in Southwest Ohio. Our Lady of Guadalupe Center in Columbus is one. El Centro here in Lorain County, just a little bit over from me. We have, entities in Toledo. There are a lot of groups already doing really great work, and we need to just sort of amplify and make sure that we allocate resources for them to continue doing their work, and then provide resources to expand their work, because there is much more probably that they can do, but they need the resources and supports. And so that's something that when we think about structural transformation, it's how can we leverage what the strengths of the community. And oftentimes these organizations are sort of the centerpiece or serve as a really great asset in these communities. And so we also want to focus on, culturally based capacity building. So our efforts, anchor institutions, healthcare systems, universities, entities like that. In terms of partnering with some of these organizations, it's really important to engage in culturally based capacity building. So being able to build capacity of those organizations, but then also build capacity within the community. But because the communities we're targeting are going to be our Hispanic and Latinx Ohioans, we want to make sure that we're capacity building in a culturally relevant and a culturally responsive way. And that might mean doing an environmental scan and needs assessment in terms of the different communities, right? And I think it's important to again, highlight the different needs of communities. As we mentioned in part one, we gathered data from different regions of Ohio. So it was Central Ohio, Southwest, Northeast, Northwest. And all of the needs in those communities, while there's some commonalities and likely to expected to be some similarities, there's going to be differences. And so it's really important to do environmental scans and needs assessments of those different communities, and not just assume that what one community needs sort of is portable to another community, because again, each community is going to be individual in and of itself. And so we want to make sure that we honor that and address that. Again, focus on commonalities and similarities, but also acknowledge that there's going to be diversity within diversity. And so we need to be able to conduct needs assessments to be able to identify those unique or diverse needs. And then we want to make sure that the services and supports that we provide are culturally informed and responsive. So anything that we design, offer, provide for our Hispanic and Latinx Ohioans, we've looked at it from a lens of cultural responsiveness. Does this fit the population? And that has to be an ongoing question when we're working with the population of interest. I also think from a public health preparedness standpoint, really, COVID-19 pandemic, I recognize, sort of caught a lot of us maybe off guard. It requires sort of an in-depth review to then help inform sort of future public health preparedness. So really, commissioning an in-depth study or examination of the experience of Hispanic and Latinxes in Ohio to inform future planning for public health emergencies is really important. Obviously, our work is, again, a very small snapshot and doesn't represent all of Hispanic and Latinx Ohioans and doesn't represent some of our even more vulnerable groups like our undocumented population, our migrant farm worker population, and so our DACA community. So it's really important to, potentially do a more thorough review of what the experience was so that it can help inform, right? We never want to repeat the same mistakes, right? And this and the pandemic offers us an opportunity to definitely learn and grow. We talked about it sort of as a point of resilience. As part of resilience is growing from the experience and sort of being able to use some of what happened as a stepping stone, to moving forward. This is an opportunity to do that. And so that's a key recommendation. A formation of a community advisory board to help inform concerns among Hispanic and Latinx Ohioans. Again, it's sort of making sure that the voice of our Hispanic and Latinx community is at the table. OCHLA operates in some capacities in this way, but it might be important to have, a community advisory board in Cleveland and in Toledo and in Cincinnati, to be able to have a community advisory board that sort of helps local entities and maybe local government address needs of the communities. And then ensuring language access throughout systems. So with public health preparedness, there was, some issues that we highlighted in the first presentation regarding an inability to access some of the materials or recommendations or knowing, the updates in terms of news updates or health updates, because language access was sometimes limited. And despite, I know people working really hard to translate materials really quickly, there wasn't like a robust system for doing so. And so how do we ensure that? How do we plan for a streamlined, robust, quick, and efficient translation of materials process and, interpreting as needed? That those systems have to be looked at in terms of how do we actually ensure that this isn't an issue moving forward. In terms of safety recommendations, so obviously, we're big proponents on ensuring that individuals have the ability to maintain safety. And as the COVID-19 pandemic wears on, it's important to keep that in mind. So limiting detention and deportation proceedings without the ability to maintain safety in those environments. So if we're detaining individuals and we're not able to maintain their safety, then that number one should not be occurring. And so really trying to look at, again, systems, and just because something can be done doesn't mean that it should be done. So we look at safety, the ability to maintain safety in those environments, and the ability to make sure that we're prioritizing safety over, typical proceedings. Adequate protection should be provided for all essential workers with resources for businesses to support provisions. So again, if we go back to the early part of the pandemic when recommendations were, stay home if you need to stay home if you're ill, quarantine if you're ill for 14 days. The problem with that is that there weren't necessarily the infrastructure, supports to provide for that for a lot of workers or for a lot of families, particularly our Hispanic and Latinx community, many of whom were deemed essential workers. And so how do we, make recommendations and prepare, for individuals to be able to implement those recommendations, right? We have to provide the infrastructure to do so. And again, that's all about structure. It's creating the structural capacity and the structural change to allow for implementation of those recommendations. And adequate protections for the safety of undocumented and detained immigrants who are particularly vulnerable. So undocumented and detained immigrants are uniquely vulnerable because of an intersection of all the different identity and sort of factors that they have. And so it is important that we ensure that we're providing for adequate protections for them. In terms of health information and health communication, so it's really important, I think, to really think about, public health emergency as an emergency across sectors and systems. And so how do we really focus on leveraging different sectors and different systems to come together in terms of ensuring that public health information is disseminated in a timely, efficient, and appropriate manner. So we have to sort of look at the integration of all of those systems, implement strategies to accelerate the communication from public health authorities. So again, as I mentioned, sort of similar to language accessibility, how do we create a system that's going to be more efficient to deliver critical information in a public health emergency, and improve the integration of communication networks with the community and the healthcare system. So, you know, our Hispanic and Latinx Ohioans identified various ways that they got their information. And so really trying to integrate some of those communication networks and those trusted communication networks so that, again, we can establish efficient systems and effective systems. And so we also, you know, heard in the first part of this presentation, or first part of the series of webinars, that some of our Hispanic and Latinx Ohioans didn't feel like they could access the available safety net resources and supports. Again, that necessitates policy changes to ensure that people are eligible and that all folks are eligible, because again, we're only as strongest as our sort of the weakest among us, and so the most vulnerable among us. And so ensuring that individuals who are vulnerable have protections, have supports, and have additional resources to, again, help them cope with a crisis. And so that may indicate the need for policy changes in those areas. And supports for resources for community-based organizations and other support services to help connect households and families to available resources. As I mentioned, those community-based organizations sort of were the hub for Hispanic and Latinx Ohioans during the pandemic. When they needed something, if they had a question, the number one place that they would say that they would go to among the people that we spoke to were those CBOs and MCBOs. And so obviously they play such a critical role in the community, and you know, all in the normal times, but then also during a pandemic are exceptionally important and critical to the Hispanic and Latinx community. So really trying to help provide more resources for them to do the functions or serve in the functions that they already were serving, build their capacity to do that. And focusing on development of an information clearinghouse where Hispanic and Latinx community members can access those resources, supports, and all of the different information that they need to access those things in a clear and sort of concise manner. So whether that's, you know, an information clearinghouse that is, you know, maintained or run by those MCBOs or CBOs, or sort of an online hub, whatever it needs to be that works for the community. Again, that's where the community feedback is going to be really important. But having some sort of information clearinghouse that provides all of the information in one place so that folks can access it in a more timely and more efficient manner. And then the digital divide. So that also posed a challenge for schooling, but it also just posed a challenge in terms of just communication and obtaining information in general. So again, when we think about structure, those digital gaps that existed already, again, just sort of became an issue that would exacerbate some of the problems for our Hispanic and Latinx community. So we really need to invest in cross-sector collaborative efforts to identify and really prepare and then deliver immediate education to technology tools and needs. And so I know people have done that, you know, since the pandemic we're on. I know there's been different partnerships with different cable companies, for example, or internet broadband companies, for example, to provide internet services or broadband services to some of our community members. But it's sort of looking at, okay, so we were able to do that. How can we potentially sustain that moving forward to help sort of lessen that digital divide that exists? And we need a plan for identifying the necessary technology, infrastructure, and capabilities to address those inequities in broadband access. Again, thinking forward. We were able to do it in a crisis. How do we maintain that? How do we sustain that moving forward? And then school disruption. So we talked about already there being educational gaps, achievement gaps for our Black and Brown youth before the pandemic. And so it's really important to note that for school disruption, especially associated with the pandemic, it had a profound effect on Black and Brown students. We even saw, you know, there's been some research recently that kindergartners, the enrollment of kindergartners was lowest in this last year than it has been in a long time. And a lot of that was, or a lot of that number was represented by Black and Brown youth and youth that live in those sort of socially vulnerable communities. And so we have to look at, again, sort of what exists in the past what has always existed in terms of laying the foundation for those realities to emerge, right? So there's reasons why those numbers and the low kindergarten enrollment is highly represented by Black and Brown youth. We need to sort of look at why that is. And so in doing that, we need to examine sort of the impact of school disruption uniquely on youth that were already vulnerable. So as you know, schools are back in session now, a lot of students obviously going to school. We need to make sure that there's varied options for maintaining contact and communication with teachers and school support staff. I think it's really important to figure out how do we create better communication systems between families and teachers. And I know teachers are doing as much as they can, and sometimes again with like limited resources, but just trying to figure out again structurally, how do we create a structure that allows teachers to do their best, to do their jobs, but then also provide parents and family members the ability to more effectively communicate and be aware of, you know, goings-ons within schools, especially when things seem to be, you know, in more constant change these days. And then we also want to provide clear communication, accessible information regarding instructional plans. So if there are going to be changes, you know, knock on wood, you know, there won't be necessarily any needed educational changes, but if there are, you know, making sure that the communication regarding that is clear. Again, at the very beginning of pandemic, so, you know, everyone sort of gets a pass, you know, it caught everyone off guard. You know, schools quickly had to transition, and they frankly did an amazing job of transitioning as quickly as they could. But that didn't mean there weren't challenges, right? There were families who couldn't access information. There were parents who didn't quite know or weren't up to speed on what was going on in terms of, you know, instructional plans. There were some children that I worked with who didn't have access, who kept losing access to the internet, so weren't able to log in for school. So really figuring out like how do we enhance that clear communication and provide information in a more accessible way for parents, especially parents who maybe are more limited in their English proficiency. And then we want to make sure that we're matching learning resources to learning needs and context. So especially, I think it's really important, that whole word of it or phrase of in context, is right now there's going to be significant behavioral health and mental health need among our youth in schools. And so really trying to think about matching those learning resources to learning needs in the context of that, but then also in the context of unique needs for individual students. And so just trying to, again, pay attention to what are some of the other factors that might be at play and addressing that or considering that in the provision of learning and instruction. And then we get to mental behavioral health. So I think I mentioned this on the first webinar, that the mental and behavioral health part of the report is actually the longest section in terms of recommendations. And it's because of just the frequency with which respondents, either on the survey or in the focus groups, indicated that mental behavioral health took a significant hit during the first part of the pandemic, and then continues to be an issue as we sort of move on. So we need to build additional frontline capacity. There is not enough behavioral health workforce to meet the needs, and that's sort of a known thing. There's always been sort of a shortage, but again, that shortage was just exacerbated with more needs in the context of the pandemic. So we need to build on we need to build additional frontline capacity. And that will also include expanding the network of non-traditional mental health providers. So mental health providers, we want to build that workforce, absolutely, but we need to be also able to invest in and support non-traditional mental health providers to be able to provide some of that mental health support in the communities themselves. So that might mean, you know, increasing the identification and utilization of cultural brokers across various settings. So allowing folks to serve in those cultural broker roles, particularly when it comes to issues of mental health. That might mean investing in some other different types of mental health educational programs. So for example, that might mean like community mental health navigator programs, bringing mental health first aid into the communities themselves. So anything that brings mental health services into the community, instead of relying on the community to leave their community and having to access in some of this behavioral health service and information elsewhere, is going to be really important. We also have individuals who, you know, may come to the United States from, you know, another country where they did work and were licensed as a mental health provider, but because of differences in licensing requirements may not be able to serve in that capacity currently. And so looking at, you know, how do we maybe, you know, alter that system where you can get that reciprocity a little bit easier and help build that workforce and build that capacity. But again, you know, looking at different ways to bring mental health into the community, focusing on school-based behavioral health, integrated behavioral health into primary care. Again, trying to reduce barriers to access by creating more access points in locations that families are more likely to encounter is going to be really important. So thinking about both the workforce and increasing the workforce, but then also looking at other ways of bringing mental health intervention into the communities themselves. We want to make sure there's sufficient insurance coverage and adequate reimbursement for behavioral health services. Oftentimes, behavioral health does not necessarily fall under, health insurance, and along with medical care, there may be like a behavioral health carve out. And so looking at, ensuring that coverage for behavioral health services is adequate and the reimbursement is adequate. And we also want to make sure that there's ongoing coverage for the different options of providing behavioral health in terms of modality. So in-person, options, like I'm in my office right now, so I do a lot of in-person care, and that's fine, but we have some families that would prefer to use telehealth or to use the telephone in accessing their care. And during the pandemic, that was really important, but it continues to be an option that may help reduce some barriers for some families. I have some families whose young children, are not able to be vaccinated right now, and so they're worried about exposing them, coming to sort of a medical office, and so they would rather stay at home and do their behavioral health visits through FaceTime or what have you. And so ensuring, again, from a structural standpoint, how do we maintain the ability to provide mental health services in some of these other ways that doesn't have to require just in person, which again may work and reduce barriers for some families. And then ensuring sufficient insurance coverage and reimbursement for language access and interpretation services. So if a family needs interpretation services for a visit, again, they're predominantly Spanish-speaking family, they're coming in for behavioral health services, depending on insurance or depending on how the entity, the organization or agency addresses the interpretation piece of it, there may not necessarily be insurance coverage for that. And so that may be, a cost that we could reduce if insurance could cover or provide coverage for interpretation services. We also want to make sure that we have the capacity for adoption of trauma-informed care, to be implemented in organizations and across organizations, because we do know that the pandemic has been, frankly, a trauma for really all of us in some ways. But we know that individuals entering a healthcare system, they have a unique experience with the COVID-19 pandemic that may also have been very traumatic for them. And so we want to create a system and create and invest in systems that are going to prevent re-traumatization once they enter those systems. And so using that trauma-informed lens is going to be really critically important in terms of thinking about how do we more effectively in our systems work with these uniquely marginalized populations. Emphasis on cultural proficiency and cultural factors as strengths in trauma-informed care. Again, we are a resilient group, we are a resilient culture, and we are a resilient community. And so looking at leveraging the strengths and the assets of the Hispanic and Latinx community in trauma-informed care and using those sort of as jump-off points or starting points when we think about, okay, how do we, help them recover from the, traumatic experience of this pandemic. So to really looking at utilizing some of those characteristics as assets, and increasing support and resources for organizations to effectively adopt and sustain utilization of trauma-informed care. Adopting and implementing trauma-informed care requires resources. It requires commitment. Obviously, it requires a willingness, a commitment, but then it requires sort of a dedication. And that dedication should be backed up by resources and supports to be able to do it effectively. We also, again, just want to, emphasize the strength-based approaches and leverage, cultural strengths in developing programming or services intended to mitigate the negative effects of the pandemic and promote positive growth. So again, whatever program or service that's being provided to try and help or facilitate recovery among the Hispanic and Latinx community in Ohio, it should be done from a culturally strength-based approach, sort of an asset framed approach, again, because we want to leverage those strengths. Those strengths are central, they're critical, and they're going to just facilitate recovery long-term. So we want to make sure that we're addressing that and utilizing that. And leveraging family community-oriented approaches for collective responsibility and community impact. We know that the family is a central piece of Hispanic and Latinx culture for a lot of our community. That's not to say it is, for everyone, but again, as a culture, as a community, we tend to have certain values. And again, I know there's some exceptions to that for sure. but we have some certain values regarding the family, regarding, social connections, social community, that we rely heavily upon, and that really serve as sort of a centerpiece or a focal point of our culture. And so it's really important to use those and leverage those in terms of approaches for collective responsibility and community impact, to treat, communities almost like a family in of themselves, and to treat communities as effective partners. And by doing that, in doing that, we can foster more of that collective responsibility and community impact if we sort of leverage that family and community orientation. So again, I just want to mention that the report is available at the link here. It outlines all of the recommendations in a little bit more detail. I think we've gone over the majority of the pieces of the recommendations, but again, it sort of outlines not only the local impact from Ohio, but also gives you just sort of a snapshot into what the national impact was like in comparison to Ohio, gives you the Ohio data that we covered in the first webinar, and then goes through, several pages of recommendations with a focus on transformational, structural transformation. I do want to mention before we sort of close today, is the report and the findings were all before the vaccine was available. But we do have a section on recommendations for vaccine uptake and dissemination. And I'll just go over some briefly here, but a lot of those same recommendations are already being implemented. So, utilizing, trusted community-based locations or environments to deliver the vaccine. So whether that's, the local mercado, or whether that's, the church or a faith-based organization for our Hispanic and Latinx community, being able to offer the vaccine at those locations, again, where they're most comfortable, easier to access, and have had the ability to do that. Pop-up or mobile clinics are really important. We know that there may be individuals who are unable to take off work to go get and schedule an appointment for a vaccine. And so that is something that we need to make sure that we're more flexible in terms of offering when it's available and how to access it without appointments necessarily. Additionally, systems, that were created initially to try and schedule an appointment, they weren't the easiest to navigate in English, let alone in any other language. So I was actually, helping family members try and get an appointment to get their vaccine, and it was hard for me to navigate those systems. And obviously, I speak English, proficiently, but it was challenging. It was challenging to navigate those systems. It was challenging to get an appointment, and so you can imagine if it's challenging for someone like myself, again, who speaks English well, who is highly educated, it can be that much more challenging for someone who has any kind of language barrier. So really trying to think of how can these systems be better equipped to be able to provide for individuals to access the system in an equitable way. Additionally, when it comes to vaccine uptake and dissemination, we need to be really clear and careful and really intentional about combating misinformation. And there's a lot of misinformation around the vaccine. And so I know this is a problem in a lot of different communities, and there's a lot of different strategies to try and address that. But really some culturally tailored messaging, for Hispanic and Latinx Ohioans, to target that misinformation is going to be really important. And that's going to continue to be important as we try and, again, increase the rate and uptake of vaccines in our community. And I think part of that is understanding what are the pieces of information that individuals are receiving that may increase their hesitancy or reluctance to get the vaccination. So again, culturally tailored messages, culturally tailored communications around these issues is going to be really important as we move forward. And then obviously providing for the opportunity, for individuals, if we can create that structure for individuals to get the vaccine. So if that means we can allow folks to go up, take off work to be able to go get the vaccine if they can't access a mobile or pop-up clinic, then those are the things that we need to be doing as well. Again, we have to think about all the structural barriers, all the structural factors that may make it harder for someone to access the vaccination, and then create strategies and systems to deconstruct that, to eliminate those barriers so that those aren't the reasons that someone can't access a vaccination. So, again, the data was collected before the vaccination, the vaccinations were available, but we do have some recommendations around that and trying to promote vaccine equity as well. So again, this is just where the report is available. This is my contact information, and I think we have some time for questions if anyone has any. And I just want to thank you guys for your time. So I will turn it back over to Angel, who I think will help close us out.
Thank you so much, Marilyn. It's always a pleasure and an eye-opening experience to hear the material that you bring, and even more so with this so relevant topic, in which our communities are being disproportionately affected uh, upon already existing inequities. So thank you so much for helping us through this material. We have some time still. I would like to present participants with our evaluation. You have the QR code on your screen, and also we will be sharing the link for this evaluation in the chat. This is the reason that we can continue to do free trainings for our population, and it's thanks to your evaluations, and your opinion is really important to us. So please take a minute or two to complete this brief evaluation. It won't take more than that, I promise you. And also please send any questions you have our way. I know Madeline will be more than happy to answer those. So uh, please use the question section to send those, and we will be happy to reply.
Yeah, and I just want to echo what Angel said, which is, the evaluations are just so critically important, right? The National Hispanic and Latino MHTTC does just such great work, and really prioritizes the needs and the unique needs of our Hispanic and Latinx community. So definitely please fill out that evaluation. It's critical to their work, and being able to sustain their work moving forward, and being able to, give more feedback to them about, what we'd like to see moving forward. So definitely take a few minutes, even if it's at the end of this presentation, to just take a few minutes before you log off to complete that evaluation.
You don't have to do it right away, like Marilyn says. You have the link on your chat, so you can open that and complete it a little bit down the road. But please do help us with that part. I'm looking at the questions section to see if there are any. Not at the moment. So participants, if you have any questions, thoughts, or questions or comments even, we love comments also. It helps with the discussion.
And no, I really do appreciate you guys like logging in and catching the first webinar, and then catching the second webinar as well. I know that eventually the links to these webinars, the videos, will also be available. So if you know anyone who did not get a chance to log in, I know we're all very busy people. So if you know anyone who didn't get a chance to log in, who would like to see the presentations, the links or the videos will be available on the website in the next few weeks. So definitely, be on the lookout for that, and feel free to share the resources. And also, again, feel free to download that report. Is located on the OCHLA website, and that also you might be able to check out the website and see all the good work that they're doing as well. So.
Yeah, you guys can see the website on screen. Also, we shared our link for the website through the chat. Feel free to browse through our material. We will be uploading this recording along with the materials for this presentation during the next week or so. So be sure to check out for that.
Absolutely.
Again, if there's any questions, we will be more than happy to answer those and share those with Marilyn. If not, then we can continue. Also, be sure that if questions arises in the future, Marilyn share her information. Also, you have the email, and my email is on screen, so you can use any and all of these platforms to reach us, and we will be more than happy to answer or help you with your inquiries.
Absolutely, yeah. So this is my contact information. So if you do have questions after this presentation, or you check out the report and you have some questions on the report, feel free, to send me an email or, get at me via one of those social media channels. I'm more than happy to answer questions. I'm more than happy to talk further about the report, our findings. I think I mentioned this on the first webinar. There's some data that's not yet been part of the report that we're sort of parsing through. So there may be sort of an update that comes along in the next couple of months once we kind of see what the data sort of bears out. But that data may be forthcoming in the next couple of months, sort of just like as an addendum, if you will, sort of an update maybe to the report. But it's just a small piece that hasn't been vetted yet. So we're going to look at that and see if it offers anything else. I can just sort of tell you based on like anecdotally, just sort of eyeballing it. Again, it just is a lot of commentary on the behavioral health and mental health impact from the pandemic. So that's something that, again, just continues to come out. And I know that that's going to be something that we continue to need to address as we move forward. For those of you who, they're thinking about like, what does recovery look like for the Hispanic and Latinx community moving forward in terms of what have people thought, it's important to note that, already there's some estimations that it may take a decade, 10 years or so for the population to fully recover from the impact of the pandemic. So this is not something that we're going to stop talking about. And this is not something that as soon as the pandemic is quote unquote over, that it goes away. Just like how we talked about the very beginning of the presentation, just like those policies have lasting impacts, this pandemic is also going to have a lasting impact, again, with estimates, at least right now, of thinking like it may take 10 years or so for the population to fully recover. So it's going to be something that we need to continually think about, be cognizant of as we move forward. And again, I think the point of this presentation today is just to think of how do we address some of the underlying mechanisms for how we got to where we're at currently, right? There's a reason that it's having a disproportionate impact on our Hispanic and Latinx community. There were reasons that existed. And so as we move forward, we really need to think about those structural issues, those structural factors in order to promote equity moving forward. So that in 10 years, assuming that estimate is correct, that in 10 years, not only has our community recovered, but we have recovered in a way that's actually going to position us much better moving forward. And I think that's really what we're sort of looking for. So I just wanted to throw out that in case people hadn't heard that. But again, it means that we're going to be thinking about this, talking about this for a long time to come.
Yeah, this is certainly a conversation to go into the future. I love how people are always stuck in the pandemic, like it happened already, but we're still in it. And there's still a long way to go, and we'll be sure to stay tuned to the reports and to continue to bring up this conversation that is so needed to bring awareness to our providers and also to our communities. So thank you, Madeline, so much for your time and being here with us.
No, thank you guys so much. I appreciate you, Angel. I appreciate Cindy behind the scenes. I appreciate all of you for attending, and I hope to talk to you all again soon.
Thank you, Madeline. To our attendees, thanks again for coming today to our presentation. Make sure to fill out the evaluation. Have a great day.